Hi, my name is Harry McGrath. I'll be discussing the chapter on the anteromedial temporal lobectomy by Dennis Spencer, Yemisi Damisa, Alexander Ksenzowski, and myself. The key learning objectives for this session are to understand the indications and preoperative workup for the anteromedial temporal lobectomy, to appreciate the important intraoperative steps, and to identify the key anatomical landmarks that guide the resection. Here, I'll briefly touch on the history behind the technique. In 1950, Penfield reported on the first series of patients treated with temporal lobe resections. He used interictal discharges sampled with EEG and intraoperative stimulation to localize seizures. 55 patients underwent temporal lobe resection. Of those, 32 patients underwent resection of half or more of the temporal lobe. The remainder underwent a partial anterior temporal resection. 53% of Penfield's patients had complete control of their seizures at 1 year of follow-up. In the mid-1950s, Falconer described his own standard variant of the resection. The Falconer resection of 5 to 6 centimeters of the temporal lobe, plus the medial structures, was used widely, with small modifications from the 1950s until the 1980s. His variant is generally thought of as the standard temporal lobectomy. In 1984, Spencer and colleagues described the modification of the technique that increased the access to medial temporal structures while minimizing the resection to the anterior inferior temporal pole and preserving the superior temporal gyrus. This was known as the selective amygdalo-hippocampectomy. Since then, a number of different methods have been described to minimize disruption to the lateral temporal cortex. In terms of the preoperative workup, it's important that a comprehensive workup is used to select those patients who may benefit from surgery. The workup is used to identify the region of seizure onset as well as spread. The workup is typically split into phases according to the risk associated with the different diagnostic modalities. The specific definition of each phase varies between centers. At Yale, we define non-invasive diagnostics, including MRI and PET, as phase 1. Phase 2 is the less invasive diagnostics, or the intracarotid Amital test, or WADA test. Phase 3 is then invasive diagnostics, or the intracranial study. Phase 4, finally, is surgical treatment. The ideal patient can be thought of as the patient most likely to achieve a good outcome following resective surgery. The patient would have a unilateral medial temporal lesion or sclerosis on MRI. They would be experiencing focal or focal impaired aware seizures on audiovisual electroencephalography or AVEEG. They would have temporal lobe specific neuropsychological deficits. They would have previously failed 2 anti-epileptic medications, and they would experience infrequent secondary generalization. When consenting patients for the procedure, it's important to convey all of the potential postoperative deficits. Here are a number of those potential complications. Visual field defects can occur from temporal lobe surgery affecting the optic radiations. Language deficits can occur for surgery of the dominant temporal lobe due to variable language representation. Temporalis muscle wasting can occur due to the reverse question mark incision that we use. Hemiparesis can occur due to injury to the anterior choroidal artery or from direct brainstem injury. Diplopia can occur from 3rd or 4th nerve injury. I'll move on to describe the operative technique with a particular focus on the anatomical considerations. To begin with, positioning is crucial for optimal intraoperative visualization. The patient is positioned supine with the head horizontal and a wedge is placed under the ipsilateral shoulder. The head is extended by 50 degrees, the nose is rotated ipsilaterally by 10, the vertex is then dropped by 10 degrees. This brings the hippocampus in alignment with the surgical field. In terms of the opening, a reverse question mark incision is used. The incision begins at the root of the zygoma and curves posteriorly and superiorly, then anteriorly to meet the superior temporal line, just behind the hairline. And on the left you can see a patient who is being prepped for this incision. For the craniotomy, a burr hole is made at the root of the zygoma, one at the keyhole, one above the supramastoid eminence posteriorly, and one anteriorly about 1 centimeter above the superior temporal line, to expose the inferior part of the frontal lobe. The burr holes are then connected with a high-speed B1 drill. In terms of the extent of the lateral resection, the temporal pole resection is limited to between 3 and 3.5 centimeters. When we apply this principle intraoperatively, we use a Penfield foredissector inserted anterolaterally until the tip touches the dura of the sphenoid wing. 3 centimeters posteriorly along the middle temporal gyrus is then approximated. To protect language, the superior temporal gyrus is spared. For the neocortical resection, the superior limit is the superior temporal sulcus. First, the pia on the middle temporal gyrus is coagulated, just inferior to the sulcus. This opening is continued along the sulcus anteriorly to a depth of 2 centimeters. At the posterior limit, subpial dissection is performed down to the middle fossa floor. The pial vessels at the floor should be cauterized. Within these boundaries, the temporal neocortex should be removed en bloc to the tip of the temporal pole. During the temporal pole resection, the temporal horn should not be entered. After the temporal pole resection, the temporal horn should then be opened and exposed. On the left is demonstrated opening of the temporal horn using the Penfield foredissector inserted into the ventricle as a guide. On the right is the exposed temporal horn, where one can visualize the hippocampal pes, the velum terminale, which becomes an important intraoperative landmark, the stria terminalis, the fimbria of the fornix, the choroid plexus, as well as the hippocampal body. Following the opening of the temporal horn, the medial temporal pole, including the uncus of the parahippocampus, is then resected. This exposes, as depicted on the left of the image, the third nerve, the middle cerebral artery underneath the arachnoid, the amygdala, and the inferior choroidal point. At this point, an imaginary line can be drawn between the inferior choroidal point and the M1 segment of the MCA. The inferior choroidal point is also known as the velum terminale. This MCA-VT line demarcates the superior nucleus of the amygdala, and tissue below this line may be safely resected without entering the temporal stem or causing injury to the basal ganglia. To further highlight this point, I'd just like to show this cadaveric dissection, which has undergone MR imaging. The MCA-VT line has been drawn here. Hopefully one can appreciate that using this line as reference intraoperatively, the amygdala can be resected entirely while staying out of the basal ganglia. During the resection, 2 Greenberg retractors are used to provide adequate exposure of the medial temporal structures, as depicted in the right-hand picture. One retractor is placed on the superior temporal gyrus, or the retractor at the bottom of the image, which provides exposure of the pes hippocampus. The second retractor, on the left of the right-hand image, is inserted under the lateral temporal neocortex, just lateral to the collateral sulcus, to expose the body of the hippocampus during the dissection of the occipitotemporal fasciculus. During the entire operation, the pia arachnoid remains over all of the critical structures depicted here. All are potentially injured if care is not taken to maintain this barrier. The critical structures are the anterior choroidal artery, the third nerve, the optic tract, and the posterior cerebral artery, as shown here. This slide just depicts the intralimbic gyrus alongside the pia arachnoid covering those critical structures. It's important to carefully dissect the intralimbic gyrus off the midbrain subpially. The next step is the dissection of the hippocampal body. In the right-hand image, one can see that the sucker is holding the body of the hippocampus up and stretching it to assist in the dissection. Also visible in these images is the lateral geniculate nucleus. Finally, after the resection, the hippocampus is removed en bloc, and the specimen can be seen here. In terms of outcomes and complications of the procedure, a low mortality rate is observed of between 0.1 and 0.5%. The most common postoperative deficit is a visual field defect, specifically a superior quadrantenopia. The majority of these are not noticeable by the patient, but become apparent on formal visual field testing. At 10 years postoperatively, 66% of patients are free from disabling seizures. In terms of predictive factors for a poor outcome, rapid seizure spread within 5 seconds and non-lesional MRI scan are the best predictors. This brings us to the end of our presentation. I hope it has been informative. In terms of other resources, I would highly recommend this YouTube video by Aaron Cohen-Goodall and Dennis Spencer as part of the Neurosurgical Atlas, where they discuss the technique in detail. Finally, here are my references, and thank you very much for listening.